after, say, prostate cancer. I see many patients after prostate cancer treatment, and I also see a lot of men for issues around sexual function. So I've been invited to give a talk today on management of erectile dysfunction. And so we'll just go through it. If anybody has like a burning question they would like to ask, I do not mind being interrupted. Otherwise, we'll have hopefully a little bit of time at the end at 12:30. I'm a consultant for a number of companies, though nothing really related to erectile dysfunction. So we'll review just a little bit of the sort of epidemiology, the pathophysiology, risk factors, because I think it's important to identify, what is erectile dysfunction. Then we can understand a little bit about the lifestyle and medical treatments, and then a little bit on the surgery. So erectile dysfunction, or ED, is defined as the persistent inability to achieve or maintain a penile erection sufficient for satisfactory sexual intercourse. Incidence is age dependent, so it becomes more common as men get older. And there are different types of erectile dysfunction. It could be psychogenic, so psychological in origin, organic, or mixed, and we'll go over those differences. So in this big epidemiologic survey of ED, first they looked at how many men between the ages of 40 and 70 report having ED. And in fact, the majority of men over the age of 40, more than 52%, will report having some element of erectile dysfunction. And it's a mix between some having minimal, some having moderate, and then some having complete. So it certainly progresses with age, but we do know that some younger men may also have ED. ED is a very prevalent condition. It increases as the aging population increases as well. And so you can see it is a common problem in every part of the world. And of course, will continue to increase in the coming decades as the general population gets older. When we look at sexual dysfunction and how it impacts quality of life, you can kind of divide up sexual dysfunction between ejaculation problems, erection problems, and desire or libido problems. And certainly those who have ED have higher levels of satisfaction or impairment in their quality of life compared to these other sexual dysfunctions. In terms of causes of erectile dysfunction, the majority is going to be physiologic or organic. There is some which is purely psychological. There's a little bit that's unknown. And of course, the causes can overlap. It can become a bit of a vicious cycle where you may have some underlying vascular disease, but of course, then you're thinking psychologically about the inability to get an erection, and that makes it harder to get one. So how do you differentiate between psychogenic or organic? So with psychogenic, it seems to be more sudden. Compared to organic, which is this gradual decline over time. With psychogenic, it's almost a complete immediate loss of erections. Interestingly, they have morning erections still present, meaning the pumping system of the blood is still working. And there's a lot of variability in terms of partner and circumstance. So for some reason, men are okay having an erection spontaneously on their own, but they can't have it with their partner. Whereas organic, as I said, it's gradual, it's sort of this incremental progression. It doesn't matter whether it's the morning, they won't get erections. And there really is a lack of erection under most sexually stimulating circumstances. So it's a pervasive problem. So what are the causes of ED? So if you look at these four guys sitting on these cafe, diabetes, obesity, hypertension, and dyslipidemia. These are the deadly quartet. These are the four things that are all linked to each other and are all linked to erectile dysfunction because they all affect endothelial function. They all affect cardiovascular function to varying degrees. And of course, the erection is a vascular organ. So when you divide down between the physiological causes of erectile dysfunction, vascular, cardiovascular disease, peripheral vascular disease, this is the main component. Diabetes is also a very big component. Some medications are actually going to cause erectile dysfunction, and I have a list of them coming up. It's antidepressants, for example. Some are related to surgery, trauma, radiation. Some have neurological causes. Some have hormone problems, but not a ton. So we often think about, we should check the testosterone, but that's not the main cause of erectile dysfunction. So the penis is this organ that has these blood vessels inside. Essentially what they have to do is the blood has to go in to the arteries, and they compress the veins. So remember, blood flows into the arteries, blood flows out through the veins. And so during an erection, essentially you're having this imbalance between flow in and flow out. In fact, the flow in overwhelms the outflow, and you can actually compress the outflow, the veins, and that's what keeps the blood essentially more in the penis than out. And that has all to do with the little molecules like cyclic GMP and phosphodiesterase. These are the hormones and the molecules that actually open and close the veins and the arteries. So why is it that cardiovascular disease tends to impact erections earlier than other issues? So what's interesting is that the artery that goes into the penis is teeny tiny. It's 1 to 2 millimeters, compared to, say, a coronary artery, which is 3 to 4 millimeters, carotid in your neck, and then the femoral artery in your groin. And so if you're having a blockage of blood flow, which artery is going to get blocked first? It's the teeny tiny arteries first. That's why you see in diabetics, it's the fingers and toes that get affected first. And so the penis is very, very susceptible to changes in blood flow and changes in blockages. And that's why erectile dysfunction is often the first early warning sign of cardiovascular disease. So in terms of evaluation, there are many, many questionnaires, standardized questionnaires that can be given out. They can facilitate dialogue, they help with the diagnosis, they can evaluate treatment. So, are they getting better? And some of these examples are either the SHIM or the IIEF. These are as short as 5 simple questions. You can Google it and you can download it and give it to men to fill out. So in terms of a diagnostic approach, as I mentioned, ED may actually be a symptom of an underlying disease. And so you can't just think, okay, there must be a problem with the penis. You have to think, is this cardiovascular? Do they have high blood pressure? Do they have diabetes? Are they overweight? Do they smoke? All of the things that can impact, say, the heart when we're screening for cardiac disease can very much impact the penis and erections. So this idea of empiric trials of therapy generally being discouraged without evaluation. So the idea is, instead of just giving out Viagra left, right, and center and say, good luck, we would really like to kind of understand why. Why is it that this person is having erectile dysfunction? So you want to have a proper history, including their sexual history, medication history, medical conditions, and psychosocial. It's generally a focused physical examination, some lab testing. And if possible, it's very nice to bring the partner into the conversation because it can help support and also sort of normalize the condition, because erectile dysfunction impacts couples as well. So there is a vast interplay between all of these different factors. So you've got the biological factors and the psychological factors, of course, but then there are societal, social, as well as the interpersonal relationship between partners. And so all of this will impact sexual health. And so I think by approaching erectile dysfunction and sexual dysfunction from a holistic standpoint, this is really going to be beneficial to our patients. So in terms of management, the history is that it's really evolved. In the early 1960s, you may have heard of Masters and Johnson. They were psychologists who really pioneered sex therapy and counseling and talking about sexual function. In the 1970s, we had the very first implants into the penis as well as vacuums. In the 1980s, they identified vasoactive ingredients, so drugs that you can actually inject into the penis to vasodilate and give engorgement of blood. And then, of course, in the late 1990s, Viagra was introduced, and then a few years later, Cialis and Levitra. And then more recently, they've been looking at things like stem cells and gene therapy to improve erections. So you have to be a little bit careful because people will buy almost anything over the internet. And these natural remedies and over the counter, over the internet are really, they're not tested. Who knows what you're putting into your body? And we really discourage the use of these medications. We did a study many, many years ago. My goodness, almost 20 years ago. I was like a student. And we actually took samples of like 20 or 25 internet bought And we found about half of them actually contained active Viagra inside it. And so you actually may be buying the real drug, it's sort of spiked, but you have to be really cautious. In terms of an approach to ED, first-line treatments are going to be things like thinking about those 4 men sitting at the bench, lifestyle changes, weight loss, getting your blood sugars under control, quitting smoking, all of those things that impact the heart, impact the penis. And so you need to take a look at that. Of course, hormone issues, if there are any, particularly, I would broaden hormones, not just to testosterone, but also insulin is a hormone, so diabetic control, etc. Second line, I think a combination of counseling is very important, as well as oral medications. And these are the typical drugs. So phosphodiesterase inhibitors are the class. So that's your Viagra, Cialis, Levitra. Third line therapies are going to be things like penile injections and vacuums. And then fourth or final are going to be surgical interventions. So lifestyle, we can do a lot with lifestyle. You need to evaluate what medications they're on. Do they need to stay on these medications if they're causing side effects? There are a number of modifiable risk factors. You can address behavioral things, drinking, smoking, sedentary lifestyle, being overweight. I mean, there's a very good amount of evidence that even if people who are overweight, if you lose 10 pounds, you actually feel better, you sleep better, your erections get better, your peeing gets better, your breathing gets better, all of these things improve. So you can definitely have a positive effect on overall health. Now, will this help your erections in the short term? Maybe, maybe not. It's going to take time for this regular exercise to help, but certainly taking these brisk walks can help reduce the risk of development of ED later in life. So first-line therapies, you've got these lifestyle and drug modifications, psychological counseling, and then of course the oral therapies and hormones. You may want to look at what they're taking and see if you can modify them. So all of these drugs have the potential of adversely impairing erections. And so that includes antihypertensives and diuretics. The SSRIs are those antidepressants. There are a number of hormonal agents that actually have anti-androgen or anti-male hormone properties. And even histamine antagonists can cause some erectile dysfunction. In terms of psychological counseling, you can use it as a therapy in and of itself or as an adjunct to other things. Some of the things you might want to focus on in the different types of therapy that are available are things like anxiety reduction and desensitization, so people feel just too revved up about getting an erection. There are cognitive behavioral interventions as well as sexual stimulation techniques and interpersonal couples-based therapy as well. So Viagra really changed the way we treat erections. So sildenafil is the compound, it's the generic. It came out in 1998, I believe. And it was originally designed as something for pulmonary hypertension, but they found that all of these lung patients were getting great erections. So they repurposed the drug for ED. And so sildenafil came out in 98, and then vardenafil and tadalafil came out about 5 years later. And so these are the commonly available drugs. Currently in 2021, all of these drugs are available generically, generic drugs. So that has certainly reduced the cost quite a bit. Now, Pfizer and Eli Lilly still make the branded versions. And of course, many patients prefer a branded drug, and you can always write "do not substitute" on the prescription. Now there's a whole new industry of being able to buy these phosphodiesterase inhibitors online. Some websites will be reputable, some will not. And in fact, there's a lot of counterfeit PD5s online as well. So it's definitely a buyer beware market. The number of counterfeit, if you look at all the types of counterfeit drugs in the world, in this study from 2007, the vast majority in orange were actually genitourinary, and that's really the PD5s. So compared to cardiovascular, people buy counterfeit statins or counterfeit PPIs or whatever. These erection ED drugs are the most counterfeited drugs in the world. And here's an example of, on the left side, real Viagra. On the right side, this is methamphetamine. So this is like party drugs. And they've made it look exactly like a Viagra tablet. You can see the difference there. So you have to be really careful and advise your patients to be careful that they should only be getting it from a prescription from a pharmacy. So if the pills don't work, there's a number of further types of treatments that are available. One is something called a medicated urethral system for erection, or a medicated urethral suppository, and it's Muse. So Muse is for men who don't respond to the pills, or they can't take the medications, or it's adverse. What's nice about Muse is that it results in a rapid, predictable erection. It can help when other types of treatments haven't worked. Now, what is Muse? Let me see if it's on. So Muse is this little system. So it looks like an eyedropper almost. And in the very tip here, you can see it's a medicated pellet. So this is a drug called prostaglandin E1. And that is a vasodilator. So the idea is that it comes in this little kit. You pull out the cap. You insert it into the urethral meatus. It goes in about 2 centimeters. You push the little body button at the top, and it will deploy this teeny tiny grain of sand, smaller than a grain of rice for sure, into the urethra. And then what you do is you have to hold the penis up to the ceiling and you massage it back and forth so that this little tablet dissolves. So it's like a suppository. And it gets absorbed right into the erectile tissue, causing vasodilation and engorgement, so blood flows in. There are some advantages. So there's no needle required. It's very safe. There's no systemic side effects like the pill, so you're not going to get a headache or blurry vision. It has no effect on sensation ejaculation. It's pretty immediate, works within 5 to 10 minutes. Doesn't matter if you've had a full meal, because with the drugs, they can not work as well if you've eaten. They're largely covered. This is mostly in the US, but some drug plans do cover it. And it really doesn't have any long-term negative benefits on the erectile tissue. The next option is something called a vacuum erection device. This is a penis pump, put pretty simply. And this is nice because there's no chemicals, there's no drugs, whether it's by mouth or into the penis, there's no needle. And essentially all you're doing is creating a vacuum seal. You pull the blood to engorge the penis. And then there's essentially this ring that's placed at the base of the vacuum. And it pulls onto the base of the penis when it's erect, and it keeps the blood in. So it's essentially like a penis ring that keeps things in. It's a very good option. I think what's nice about it is that you don't have to take drugs, as I mentioned. There's no contraindications. Anyone can use it. You have to have a bit of dexterity, of course. It's a one-time cost. So these things can be as cheap as a few $100s, and they can become like very, automated with batteries and work, high end, but $300 to $600 range, let's say. I'm sure there are very cheap models out there as well. So the basic principles, as I mentioned, is you put it over the penis, you get engorgement, you pump it up, it draws blood in, and then you put this constrictive ring on the base. It does require manual dexterity. There's teaching. I often tell people just look on YouTube. 5-10 years ago, we used to give people DVDs, but nobody uses the DVD disc anymore. We tell people to not leave it inflated for more than 30 minutes. Remember, it's like squeezing your finger and it turns purple. So there's not a lot of blood flow in and out. You're essentially getting some ischemia. So you don't want to make your penis ischemic. So therefore, don't have the ring on for more than half an hour. You have to be a little bit careful with people who are on blood thinners or can bruise easily. And it has a pretty stable satisfaction rate, particularly in people who are in long-term relationships. So you're not going to pull out your penis pump on like your first date with someone. You need to have a stable partner. It's quite good. Patient satisfaction, 50% over a number of years, on-demand use, no systemic issues, but it can be a little bit uncomfortable, a little bit cumbersome. It's not really a natural erection. Some people don't like it. So some people love it, some people don't, but it's worth a try. So this is injection therapy next. This is called intracavernosal injection. So those cavernosal bodies are the erectile tissue. We use a very tiny 28 gauge needle. So it's essentially an insulin needle, same that diabetic would use for insulin. And you use a very small amount of this combination of vasoactive vasodilatory agents. So papaverine, phentolamine, prostaglandin. It typically gets mixed up at a compounding pharmacy, and it can be injected as a tiny amount, typically 20 units or 0.2 milliliters, so a fraction of a milliliter. The idea is to essentially hold the penis on stretch, inject on the side. Doesn't matter if it's the left side or the right side, the needle has to go all the way in. We usually recommend starting at 20 units or 0.2 milliliters, and they can always increase the dose by 0.1 at a time. And it does also result in a pretty instantaneous erection within a few minutes. It's good for people who didn't respond to the oral medication or couldn't take the drugs. And it really does give a reliable, instant, predictable option. I think it's actually less cumbersome than the vacuum, and it certainly is the preferred route that we use for men who don't respond to oral therapy. It's highly effective. It's much more natural compared to a regular erection. It's much more similar. It doesn't impact sensation. There's even a bit of higher level of discretion. I mean, there are people who will excuse themselves, go to a bathroom, inject, and then come out 5-10 minutes later and they're ready to go. So it can be used discreetly, of course. In terms of disadvantages, there's a fairly high dropout rate over time. Some people don't like if there's any bruising, or they can get a little bit of fibrosis at the injection site. You always have the risk of something called priapism, which is a long 4-hour erection, which is a bad thing to get. It can be challenging for people who are obese or don't have good dexterity. It does require some training. We like to train people. Obviously, some risk factors with comorbidities. And then lastly, there are these penile prosthetics. This is actually surgery that we perform. So not every urologist does this, but a few in Ontario do what's called prosthetic surgery. Excuse me. And essentially the principle is that you put in a cylinder on the left and the right. You kind of core out the erectile bodies, the corpora, to put these cylinders in. And there are a variety of different models that can either be bended down and up, called malleable, or there's even what you're looking at here, which is inflatable. So there's a little pump that's placed down in the scrotum, and you pump it to move water from a reservoir into the cylinder. So it's like those old Reebok pump shoes, and it puts water to go into the cylinder. So as I mentioned, there's a whole bunch of different models out there. This is a malleable model. So think of this more like a light switch. You bend it down or you bend it up. It doesn't engorge. It doesn't get fatter or thinner or longer or shorter. It's almost like this permanent erection. It's just really tucked down out of the way or tucked up into position. That's called a 2-piece, and this is a 3-piece inflatable prosthesis. So it's a number of different options available to men. Now, notably I'll just say in Ontario, the penile prostheses are generally not covered in the hospital budgets, unfortunately. It's one of these gray zones where there's an OHIP code, but the hospitals don't have a budget to pay for it. So some hospitals have a budget for a few per year. And some hospitals, what ends up happening is the patient pays for the device and then it's put in for free. So anyway, I think in conclusion, excuse me, erectile dysfunction, it can be identified, it can be managed, it can be done in a primary care setting. You have to think about it, detect it, think about what are the underlying causes, run through your list of cardiovascular, diabetes, obesity, lifestyle things, hormonal things. It's a pretty straightforward workup. And of course, as I mentioned, there are a number of really great treatments. And the vast majority of people will respond to some combination of lifestyle, behavioral changes, and the phosphodiesterase inhibitors, the pills. A small segment, of course, will need something more invasive like the vacuum or the injection. But of course, fortunately, the pills are really the mainstay of treatment. And what's nice is that they work, the medications work kind of regardless of the etiology in many cases. Even psychogenic, we have these young men who just, for whatever reason, can't psychologically get an erection. We often give them a PD5 to boost their confidence and allow them to perform when they want to. So in the future, I think there is going to continue to be an increasing range of options. I think these drugs are great. There may be new ones coming out that have better efficacy, less side effects, maybe longer duration. And then, of course, there'll be some other agents on the horizon as well. So with that, I'm going to stop sharing, and we actually have about 15 minutes for Q&A. So thanks for joining.
So I don't know if you can see it or not, but there is a question already.
There's a question, yeah.
In the chat. Can you comment on duration of ED?
In regards to diagnosis, yeah, I mean, I think, 3 months is a relatively short period of time. So I think, if someone gets referred to me, they're like, one time, especially these younger guys, I'm like 28 years old. It's like this one time I went out and I drank too much and I couldn't get an erection and it freaked me out. And they're like, they get referred to a urologist. That's not it. So it really, I think, yes, the definition of ED on my very first slide is the persistent inability to maintain or attain an erection. And so I think 3 months is a very reasonable amount of time. But generally, remember, if it's organic, it's this slow, incremental loss of function over time, right? And so it may be over months or even years where you see it. Any other questions?
Feel free to unmute yourself if you wish to ask. I'm wondering if you see much in the way of cancer patients having erectile dysfunction and how.
Yeah, so I think, so obviously it depends on the type of cancer patients. I mean, those who are prostate cancer patients and even maybe a little bit bladder cancer, the genitourinary system is affected. Specifically to prostate cancer, the number one thing that is impacted by surgical treatment is going to be erections. Secondary to that would be continence or incontinence of urine. And so, those men who have had even radiation can have impact on erections. The big difference between surgical removal of the prostate and radiation for the prostate in cancer is that the erections with the surgery, it happens immediately where they lose erections. And it actually takes time for the erections to come back, and they never come back to where they were prior to surgery. With radiation, it's actually a steady decline over time. So radiation is sort of the gift that keeps on giving. You sort of fry the prostate and the nerves for erections, which run on the outside of the prostate, like skin on a fruit. And the radiation causes damage to those nerves. And so over time, that damage continues to progress and progress. And so a lot of men develop erectile dysfunction 5 years or 10 years after their radiation. And of course, those men in those years are now getting into their 60s and 70s and 80s because they got treated a decade earlier. And of course, those men in those decades are already at risk for erectile dysfunction. So it's sort of like a double hit. Other types of cancers in other parts of the body, I mean, there are a number of treatments, particularly things like chemotherapy, that can have impacts on erections and very much on libido. If you are taking chemo for whatever, liver, pancreas, brain, and you're fatigued and you're nauseous and you're losing your hair and you can't get out of bed and all of these things, your libido is going to take a hit for sure. And when your libido is in your boots, your erections aren't going to be that great either. And so, sexual health amongst all cancer patients is often overlooked, but it's certainly an important aspect to look at in their care. We're expanding our prostate cancer sexual health survivorship clinic to all cancers at Princess Margaret Hospital this year. So there's going to be a brand new team of physicians. It's like 20. It's huge. And this will include women as well, because women have a lot of sexual dysfunction for a variety of their treatments as well. And so it's actually a very exciting time to finally address sexual health concerns amongst cancer patients broadly. Any other questions? I mean, I can keep chit-chatting. I mean, I think the lifestyle stuff, I think, is some of the hardest to implement, and yet it really is helpful. Anything that you can think of, as I said, that's good for the heart will be good for the penis. I know it's a funny sort of thing to say, but being able to get on a treadmill, go for walks around the block, eat healthier, lose a little bit of weight, that will have dramatic, real improvements in erectile function for many men. And certainly the pills will work better. So if you sort of have a better base for which the pills can work on, so that's often something that we encourage. The difference between the pills, I have to say, it's very idiosyncratic. We have people who respond very well to Cialis and not Viagra, other vice versa. The thing to bear in mind is Viagra has a shorter half-life. So that means once you take it, it's typically around your system for 6 to 8 hours. And it's impacted negatively by food and alcohol, especially fatty foods. So if you have a big, steak dinner with potatoes and 2 glasses of red wine, and then you go home and take a Viagra, it's not going to work very well. So we recommend waiting 2 hours, quote unquote, take it on an empty stomach. So after a meal, probably 2 hours. A heavy meal like that might take longer to empty your stomach. The nice thing about Cialis is that it's not impacted less by food and drink. And so it tends to be a little bit easier to take in terms of lifestyle. And the other advantage is that the half-life is closer to 17, 18 hours, meaning that it lingers in your system for much longer. So in fact, it's broken down longer. So if you took a pill on a Friday night, it's still going to be around, Saturday morning, for example. And so for a lot of people, they find that very convenient. And then some of the side effects that are typical of these pills are going to be things like headache. People get a lot of headache. They can get some blurry vision. Nasal stuffiness is a really big one. With Viagra, some people have described having a blue haze to their view. And the reason is because there are phosphodiesterase receptors in the eyes, different ones. So like phosphodiesterase 4 or 6. And same with muscle aches, particularly with Cialis. People can get some achy muscles, particularly in the back. Excuse me, again, because there's other phosphodiesterase receptors like 6 in the muscles. The major contraindication to those drugs, when everyone remembers the Jack Nicholson scene from that movie where he took the Viagra and then he got taken to the hospital with a heart attack, and they're like going to give him a drug, nitrates, to open up his heart. And they're like, did you take any Viagra? And he's like, So you're not supposed to take nitrates with phosphodiesterase inhibitors, because the goal is to lower your blood pressure, and they both lower your blood pressure. So you can get a very dangerous dropping of the blood pressure. Yeah, does that stimulate any other questions? I think the conversation around erectile dysfunction obviously has changed a lot over the last 25 years. It was really not a common discussion point. And I think, when Viagra came out, everything changed. You had these spokespeople, you had Bob Dole, you had all these people talking about erectile dysfunction for the first time. Excuse me. And I think the stigma has largely been diminished. I think a lot of men will still be shy and embarrassed to talk about it. So, if you're in primary care, if you're in nursing, a lot of your patients aren't going to mention it. So it is, I think, one of those things to ask, to screen about. Something as simple as, are you satisfied with your erections? Because it sounds like, yeah, I'm satisfied. There's no problem here. some people are very satisfied to be able to get a half erection. And also, sexual activity does not necessarily mean penetrative intercourse for everybody. And I think that's something that we really try and emphasize in the prostate cancer clinic, is that, these are these men who are recovering from cancer, they can't get an erection. and we really emphasize that, like, you can have a very full, enriched, intimate relationship with your partner there are many other things you can do, and you don't have to be able to get 100% firm erection every time. And sort of just shifting the conversation and the emphasis is actually really helpful. So I think that's also really important. There's another question about having heart and vascular issues, not taking nitrates. There's a long list. It really is the nitrates, as far as I know. I mean, there are other drugs that can cause lowering of blood pressure. I've been asked, even alpha blockers, which are drugs we give for BPH. So tamsulosin, Flomax, they can also technically lower blood pressure. And every now and then I'll get some pharmacy call me up saying, oh, you're giving Viagra and Flomax to a patient and they both reduce blood pressure. And I guess it's theoretically possible, but it's not something I get really worried about. It's not dangerously low levels of blood pressure. Now, if you have a patient who has chronically low blood pressure, then yeah, of course, you have to exercise some caution. I don't know off the top of my head all the other drugs that are contraindicated. There may be some, but the biggest ones, like absolute contraindications, will be like nitroglycerin, right? So people who have the spray for unstable angina, that's the one that we really worry about. We have a lot of patients who have heart issues, quote unquote, who've had heart attacks in the past, who have high blood pressure. And for whatever reason, they have this perception and their caregivers, whether it's primary care or the nurse practitioner, say, oh, you can't take Viagra. Well, the truth is they can, as long as they're not taking a nitroglycerin patch or spray, it's fine. I mean, we used to have this rule of thumb, like, can you walk up a flight of stairs? Yeah, well, then you can have sex. You can take a Viagra. Excuse me. So I do think that is a good rule of thumb, but there's absolutely no contraindication to having had a heart attack 5 years ago and then having ED now and not being able to take Viagra. So I think that may be a misperception that's out there that can be dispelled.
Are there any other questions for Dr. Elterman?
You have any other questions about BPH or overactive bladder or anything like that? You can ask me too. We've got 4 minutes. I'm an expert in those things. So if you have any other urology questions that are burning, you can ask them. I don't mind. One of the one thing that is a nice sort of bridge between the two is that most people, a lot of men who have, as you know, 52% of men will have erectile dysfunction, and about 50% of 50-year-old men will actually have enlarged prostates, BPH, urinary issues. And one of the uses of Cialis, tadalafil, is to actually treat urinary symptoms from BPH. So it's been shown to improve urinary symptoms as much as Flomax, tamsulosin, and alpha blockers. With Flomax and alpha blockers, doxazosin, terazosin, tamsulosin, silodosin, they all have side effects. They can also give lightheadedness, dizziness, retrograde ejaculation. But you can actually give Cialis in its lowest dose, 5 milligrams, which is 1/4 the strength as the maximum dose. And if you give it to men on a daily basis, and this is approved, this is on label, it helps with their urinary flow. But the added benefit or the side effect of taking this is better erections. So when I have a man coming in who's like 65, his erections aren't so good, and he's got urinary symptoms, one of my preferred options, in fact, would be to give him tadalafil, Cialis 5 milligrams daily, because you're kind of getting two birds, one stone. And so that's sort of a nice link, interestingly, between my ED talk and BPH, which is the other thing. The one last question here from Hannah on PSA and BPH. So PSA is prostate specific antigen. So it's actually technically an enzyme. It is only made by prostate cells. Nothing else in the body makes PSA. And every little cell is a little PSA factory. And what happens in BPH is that you get more cells being made, and therefore the PSA goes up. And what happens with prostate cancer is that a prostate cancer cell is like a super factory of PSA. So prostate cancer cells make more PSA than benign cells, okay? So think of them as like these super PSA factories. So that's why when people have a little prostate cancer tumor, the PSA goes up much faster because the little cancer cells are making more and more and more PSA than the benign cells. So the challenge in interpreting PSA is it because the prostate's enlarged and making more PSA, or is it because you got these little cancer factories making more PSA? So we look at a number of things. We look at the size of the prostate. If I see a little tiny prostate with a really high PSA, I get worried about cancer. It doesn't make sense, it's discrepant. But if you have a huge prostate, it does make more PSA, it makes sense. And so you can look at things like the PSA free to total ratio, you can do MRIs, you can do all these other things to try and differentiate them. But that's sort of that interplay between PSA and BPH. Anyway, thank you so much for having me. If there's any other follow-up questions, I'm more than welcome to answer them through Kathy. You can email them, and otherwise, wish you a really great day. And thanks for the invitation.
Thank you so much for presenting. That was exciting news about the new program at UHN for erectile dysfunction and cancer patients. And yeah, it was very useful information.
Awesome. Thanks again. Have a great day. Thank you. Bye. Bye.